Hi, thank you very much for clicking on our presentation of our study published in the American Journal of Rheumatology. My name is Dr. Ming-Yen Ng. I'm a clinical associate professor at the University of Hong Kong. The study I'm presenting today is the prognostic utility of left atrial strain from MRI feature tracking in ischemic and non-ischemic dilated cardiomyopathy, a multi-center study. These are my disclosures. So a bit of background, which might be familiar to you already, is that dilated cardiomyopathy is characterized by impaired systolic function, left ventricular dilatation, and it's not attributable to valvular or congenital heart disease. And the key thing that makes dilated cardiomyopathy important is the fact that it carries a worse prognosis compared to many other cardiomyopathies. So far, we have, as a community, been focusing in terms of prognostic markers on two particular markers: late gadolinium enhancement and feature tracking in terms of MRI assessment. So feature tracking is really a technique that we use for determining strain. And we do this by looking at cine images, which are commonly acquired, so therefore you don't need to lengthen your examination time. And then what we do is we draw contours around usually the left ventricular wall, and then the software will allow us to perform strain analysis. So feature tracking strain parameters have shown prognostic and diagnostic utility in various cardiac conditions already. Now I'm going to, just because it's quite long to keep saying feature tracking, I'm going to call it FT. So CMR-FT has been shown to be prognostically useful in ischemic and non-ischemic dilated cardiomyopathy in a previous publication by our group published in the same journal. We've also shown that CMR-FT is helpful in diagnosing HFpEF if you look at the left atrial strain. And if you, in terms of a systematic review and meta-analysis, we also showed that CMR-FT global longitudinal strain for the left ventricle, together with the multiple papers, has shown prognostic utility. So left atrial strain has had a lot of interest, and the reason why is because the left atrium is key in modulating LV filling. So left atrial motion can be divided into the reservoir, the conduit, and the booster phases. And what do I mean by this? So the reservoir phase is really the whole strain, meaning the whole change in deformation of the left atrium, as illustrated in this graph. If you then look at the conduit phase, this is really the phase where the left atrium is passive and blood is just passing from the pulmonary veins into the left ventricle. Whilst the booster phase is really where the left atrium gives that little bit of a push of the blood into the left ventricle. So CMR-FT can perform left atrial strain analysis. And the knowledge gap that we were trying to address is really the lack of literature looking at left atrial strain in DCM patients. And particularly, we really wanted to compare it with LGE and LV-GLS. LV-GLS being LV global longitudinal strain. So our study aim was to evaluate the prognostic utility of FT left atrial strain, abbreviated LAS parameters, in patients with ischemic or non-ischemic dilated cardiomyopathy, and compare this with LGE and LV-GLS. So this was a retrospective multi-center study which received IRB approval, and informed consent was waived, at least as a requirement for this study. The search was conducted in 5 centers, which had just over 13,000 cases. We removed about 12,000 of these because they did not fulfill the criteria for DCM. This was the criteria we were utilizing to identify the DCM patients. And please note that the parameters or the cutoffs for dilatation were pertinent for the Chinese population. We removed the further 5 patients because there were some other diagnoses other than DCM that could account for the appearances. This left us with 898 patients, but we removed the further 80 plus patients for suboptimal images, incomplete medical records, and duplicates. So this left us with a final sample size of 811 patients, and of which these 811 patients had 193 deaths, 357 heart failure hospitalizations. The patients were scanned on a variety of scanners: Siemens, Philips, GE, 1.5 Tesla or 3 Tesla. And the images were all gathered and analyzed in a single core lab, and we used CVI-42 to do the analysis all analysts were blinded to patient clinical outcomes. For LAS and GLS, we did the analysis on the 2 and 4 chamber cine long axis images, whilst LGE was performed on PSIR short axis oblique images. And we set a cutoff of more than 5 standard deviations, and we performed manual changes in order that only LGE that was visible were quantified. So in terms of clinical follow-up, we used the electronic medical record system that's actually present for the whole of Hong Kong as a territory. So any patients that pass away or get admitted for heart failure hospitalization in any hospital beyond the 5 units that we gathered the CMR images, we would know about it. The primary outcome for this study was all-cause death and heart failure hospitalization. We did the typical statistical analyses of checking whether our data was normally distributed for continuous variables and appropriately using Mann-Whitney U-test or t-test, depending whether it's normally distributed or not when we were comparing patients with and without primary outcomes. We then conducted a univariable Cox regression modeling to identify patient factors which were associated with primary outcomes. We then performed multivariable Cox regression modeling and only selected the variables with p-values less than 0.05, except for certain circumstances, which were certain variables like LVGLS and LG, which we put into the models regardless, because we wanted to know what the significance was. The left atrial strain was divided into the 3 different parameters, reservoir, conduit, and booster, and they weren't placed in the same models because there was collinearity between the 3, so we have 3 models. For Kaplan-Meier, we plotted the strain parameters and the LGE by tertiles and then used log rank test to assess. In terms of results, as mentioned, we had 811 patients across 5 units, and the median follow-up period was about 995 days, which works out to roughly about 2.7 years. So we had a total of 419 patients with major adverse cardiovascular events, which I've abbreviated to MACE. Please note that the total number of MACE events doesn't equal the deaths and the hospitalizations combined, because some patients had both events. So I'm going to try and go through these results relatively quickly, because I think you can go back and have a look at these results. But as you can see, these are the patient characteristics comparing patients with outcomes and those without outcomes, and the variables highlighted in red are the ones that are significant. We also looked at medications, which are listed here. These are the CMR parameters, and for this table, I really want to highlight 2 main points. One is that the strain parameters are all significant in terms of comparing patients with outcomes and those without. And interestingly, LGE is not significant. And please note that we looked at LGE presence as well, which is essentially a binary outcome, whether LGE was present in patients or not. And then we also looked at striatal LGE presence, meaning that whether there was an LGE stripe, not necessarily in the septum, but anywhere in the left ventricle. And then we also looked at the typical striatal septal LGE presence to see whether this was significant. And as we can see, this was not the case. So for univariable analysis, age, hypertension, diabetes, and AF were significant predictors of outcome. In terms of drugs, ACE inhibitors, beta blockers, diuretics, digoxin, and metformin were significant predictors. For the cardiac MR parameters, essentially the same parameters came up as being significant. And again, pointing out that the left atrial strain parameters and LVGLS were all significant. And again, LGE was not significant. Nonetheless, all of the strain parameters and the LGE were inserted, except as pointed out before, the atrial strain parameters were separated in 3 models. And as you can see, reservoir strain was an independent predictor. GLS and LG are not significant predictors in this model, despite being included. LA conduit strain was significant. Again, LGE and GLS are not significant predictors. However, in model 3, LA booster strain was no longer significant, but LVGLS was significant. LGE, on the other hand, was still not significant. These are the Kaplan-Meier plots, and as you can see, the p-values are is less than 0.001, with nice separation of the tertiles for LA reservoir strain. This is conduit strain, which again shows similar findings. LA booster strain shows relatively similar findings with maybe not as great separations. Global longitudinal strain, and LGE, which shows no separation of the curves. So in summary, our study shows that LA reservoir and conduit strain are significant independent predictors of all-cause death or hospitalization in multivariable Cox progression. LA booster, on the other hand, is significant for univariable analysis, but not multivariable analysis, whilst LV global longitudinal strain is a significant predictor in both univariable and multivariable analysis, as long as it's not in the same model as LA reservoir or conduit strain. And LGE was not a significant predictor in any of the models. So in summary, LAS reservoir and conduit strain are predictive markers in DCM, having greater prognostic utility than LV, GLS, and LGE. And with that, I thank you very much for listening.